Hello everyone, I am Dr. Jayant Kumar and I shall be presenting a case in the Case Curios series. My presentation is about a case of idiopathic bilateral multilayer fovea macular retinoschisis in a young female. A 22-year-old female patient presented to us with defective vision in both eyes for the last 1 year, and she had a history of wearing glasses but no family history of similar complaints. Anterior segment examination was normal in both the eyes, and she had a best corrected visual acuity of 6/12 partial in the right eye and 6/18 in the left eye. Fundus examination of right eye showed discrete areas of serous detachment, and the extent of which was clearly seen on autofluorescence. These are the pictures of the left eye. OCT was done, which showed schisis in multiple layers of retina, along with the presence of subretinal fluid, and SRF even extended nasal to the disc in the right eye. And these are the OCT pictures of the left eye showing similar presentation. Next, FFA and ICG were done for both the eyes, which did not reveal any leak and did not give any evidence of any inflammatory pathology as the underlying cause for these presentations in both the eyes. ERG was done for both the eyes and was found to be normal with no electronegative wave form presentation. Thus, we were left with a lot of differential diagnoses, but one by one we could exclude all of them. If we see the patient was a female and had no family history, ruling out JXLR, optic disc pit was normal, ruling out optic disc maculopathy, and there was no family history or history of night blindness or peripheral retinal pathology, and there was no rise in IOP or glaucomatous optic disc or presence of PVD, ERM or VMT, thereby finally making us come to the closest differential diagnosis, which was stellate non-hereditary idiopathic fovea macular retinoschisis. This was an entity described by Ober et al. In 2014, where they suggested it to be a pathology which could be unilateral or bilateral, and the characteristic feature was the presence of stellate appearance at fovea, along with the schisis mainly in the outer plexiform layer. As we can see some of the prominent features of this entity, it can be unilateral or bilateral, has a female preponderance, and visual acuity is relatively spared. OCT findings typically show schisis at the outer plexiform layer with lesser involvement of outer nuclear layer, and fluorescent angiography does not reveal any leakage or staining. As far as our case is concerned, the unique features were that it had splitting at multiple layers, including the outer nuclear layer. It had a lack of characteristic stellate appearance, and there were no other features which could point to any other pathology. Hence, we feel that our case is a new idiopathic entity, and probably we need a cluster of more such cases along with genetic testing to clearly identify and pinpoint this new idiopathic entity as a new diagnosis. Thank you for listening to us.
This was an excellent case presentation by Dr. Jayant and his team. They basically presented a case of bilateral idiopathic foveomacular retinoschisis in a young female, where they went on to make a DD on the basis of retinoschisis in both the eyes, and they concluded that SNIFR is the most closest diagnosis. Now, in addition to retinoschisis, I think we need to look into another findings which were seen on OCT as well as autofluorescence in this particular patient. So first on OCT, we could see that in addition to retinoschisis, there is a large neurosensory kind, a detachment kind of picture in both the eyes. And if we see carefully, we can see particular deposits on the outer surface of the photoreceptors as well. So now this whole picture goes in the favor of best dystrophy, where we can see subretinal detachment, outer deposits on the outer aspect of the photoreceptors, and some retinoschisis as well. Now, going further into the autofluorescence findings, we can see there is multiple subretinal hyperreflective autofluorescent deposits present in both the eyes. Now, this again goes in the favor of Best dystrophy. But one thing, as Dr. Jayant mentioned, there was no family history. And the OCT picture what Dr. Jayant presented is very, very typical of autosomal recessive bestrinopathy. So I think basically we are dealing with the case of autosomal recessive bestrinopathy here. And again, ERG was done, and of course, ERG tends to be normal in patients with Best disease. And EOG done in this case would give us a definitive diagnosis. And of course, genetic screening, if it can be done, will confirm the diagnosis. Thank you very much.